بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, we are going now to discuss the issue of pediatric chest, and this is a long subject, as you all know. And we have divided this subject into 4 or 5 parts, starting by the anatomy and the techniques. Then we'll proceed with the focal pulmonary lesions, and finally we'll discuss the pulmonary masses which are seen in the pediatric age group. Then you know that we have many imaging modalities for evaluation of the chest in both adults and the pediatric patients, including the conventional chest X-ray, the CT, MRI, and some of the interventional techniques. The X-ray, the conventional X-rays are much more important in the pediatric age group compared to those in adults, as we try our best to save the children excess radiation exposure, especially in the CT scan. So I will emphasize the essential needs for the CT scan in the pediatric age group whenever we are examining the chest, and I will show to you the value of the chest X-rays as well as the value of CT whenever it is indicated. Actually, the indications for thoracic CT scanning in the children is almost similar to those in adults, and they include number one is to assess an equivocal plain X-ray finding, and this is a frequent indication. We have to start by a chest X-ray, and then we try carefully to reach the diagnosis considering the patient's clinical condition. But if we fail to do so, we may go to the thoracic CT scan. Then staging of lung neoplasms. This is an indication which is evident in adults, and sometimes we need this in the children. The metastatic workup of extrathoracic malignancies, children with primary malignancies like osteosarcoma or Ewing sarcoma, we want to know if there are pulmonary deposits. The plain X-ray is not that good for accurate evaluation, especially if the deposits are small. Then we may need the assessment of the chest by CT. Also, in cases of diffuse lung disease, we need the help of high-resolution CT and diagnosis of bronchiectasis, and in some cases of chest trauma, especially if they are associated with hemodynamic instability. Also, the CT scan is valuable in evaluation of mediastinal masses, since the plain X-ray is relatively weak in this domain. And sometimes we need the help of CT for evaluation of the chest wall. In order to have a CT scan of the chest of a child, we may put the child on the CT machine table, and we start first by the scanogram, and the scanogram is just a preliminary image of the part to be examined by CT, and we usually select the scanogram to be in the frontal view, not in the lateral view. And whenever we have the scanogram, we specify the scanning area by putting two lines, the first one at the beginning of the thorax and the second one at the end of the costophrenic angle. In any CT machine, you put these two lines, the machine will ask you about the scan interval, and that's to say, would you like to have sections between these two lines every 1 centimeter or half a centimeter, or what do you think about this? And then you have to specify the scan interval, and we usually scan the pediatric chest at 10 millimeter scan intervals, but sometimes we may scan at 7 millimeter scan intervals. Then the machine will ask you about if you would like to inject contrast media intravenously. The contrast media used nowadays may include the isobest, Telebrix, and any other contrast material which is usually used for evaluation of the urinary system. And the regular dose of contrast media is related to the body weight, and it is in the range of 1 to 2 milliliter per kilogram body weight. And not every child is indicated for injection of contrast material. We inject contrast media to enhance the vascular structures in the mediastinum so that we can separate the vessels from the non-vascular masses. And this is, of course, the thymus, and it can be easily separated from the pulmonary artery as well as the rest of the vascular structures in the mediastinum after injection of contrast material. But if you are concerned with pulmonary lesions, usually you do not need to inject contrast media. And these indications include evaluation of diffuse lung disease, searching for bronchiectasis, and screening for lung deposits, and in some cases of minor trauma, including rib fractures and pulmonary contusions. Then we scan the chest, as I have mentioned, at 10 or 7 millimeter scan intervals from the apex of the lung to the end of the costophrenic angle, and the sections are displayed in two window settings. The first one is known as the mediastinal window, where you can see the mediastinal structures, but you can see the details of the lung. And the second one is known as the lung window, where you can see the details of the lung, but you cannot see the mediastinal structures. And if you have one of the recent machines, the multi-detector CTs, you can order the machine to reconstruct these axial images into coronal plane like this one, or sagittal plane, which is almost similar to the lateral chest X-ray. Then the machine can help you in doing this. And you may remember that I have explained this many times in the previous CT machines, which are known as the spiral CT. We have an X-ray tube and a detector, which is in front of the tube, and the patient is in between. In order to have a section in the human body, the tube and the detector have to move a full circle around the human body. Then by each movement you get a single section in the body, and so and so. But what happens if you put in front of the X-ray tube more than one detector? And this is the new machine which is known as the multi-slice or the multi-detector CT. If you put 4 detectors in front of the X-ray tube, then you got 4 sections per tube rotation, and you can reduce the scanning time to the quarter the time of the spiral CT by using 4 detectors. But nowadays you all know that the detectors in front of the tube has been tremendously increased, and you know that the latest machine have about 640 detectors in front of the tubes. Then you can have a very fast scanning, and you can have these facilities doing these 4 major benefits. Number one is the very rapid scanning. Number two is the vascular imaging. You can see the vessels by just injecting contrast media inside the vein. Then you order the machine to scan whenever the contrast medium have reached the desired vessel. Also, you can do a virtual endoscope to any part of the body, including a tube, you can go through it. And also you have the vertical reconstruction. As I have shown to you, you can reconstruct the transverse sections into the coronal plane or the sagittal plane or even in a 3D reconstruction. Then vascular imaging is one of the major advantages of multi-detector CT, and this is an example, and this is a case of coarctation of the aorta, and you want to diagnose this, you inject contrast medium intravenously, and you order the machine to scan the chest whenever the contrast media is in the aorta. Then you reconstruct the image like this one in the sagittal plane, and you see the ascending aorta, the arch of the aorta, and you see the site of coarctation, which is distal to the subclavian artery in a simple, non-invasive way. Also, you know that for the diagnosis of sequestrated lung segment, and you need to see a vessel coming from the aorta to the suspected sequestrated area. And this can be also performed very nicely by the multi-detector CT, inject contrast media intravenously, then you scan the thorax at the time the contrast material is in the aorta, and this is a 3D reconstructed image showing a vessel coming from the aorta to a certain area in the lung, confirming the diagnosis of a sequestrated lung segment. I will discuss this in full details during my talks in the pediatric chest. Then we are going to have a look at the anatomy of the chest by CT, and this is exactly similar to those in adults, except for the presence of the thymus, which is seen in the pediatric age group and not seen in adults. Whenever you have scans in the chest, and you start first by looking at the mediastinal window to identify the mediastinal structures. Then you look to the lung window to identify the lobes of the lung. Then starting by the mediastinal anatomy, first of all, you should identify this structure, which is the arch of the aorta. And the arch of the aorta is known by most of the chest physicians as the banana. It may look like the banana, and then you put your finger on the arch of the aorta, then you will see adjacent to the arch of the aorta the superior vena cava. Then nothing in the anatomy in this area except for the arch of the aorta and the superior vena cava. And in children, you will see this structure retrosternal, and this is the thymic gland. If you go up, if you go above this section, you will see the branches coming out from the arch of the aorta. And these are the left subclavian, left common carotid, and the innominate artery. And here are the three branches, the left subclavian, left common carotid, and the innominate artery. Also, you will see the innominate vein on the left side crossing the midline to join the right innominate vein to form the superior vena cava in the lower section. Then if you go below the level of the arch of the aorta, this is the level of the arch of the aorta, and you see the arch of the aorta and the superior vena cava and the thymic gland. Then if you go down, then you are cutting here, the arch will divide, or you will see part of the ascending aorta and the descending aorta. And this is the section. Here you see the ascending aorta and the descending aorta, the arch is dividing. Then you see the superior vena cava also and part of the thymic gland. Then if you go more down, then you will see the ascending aorta, the descending aorta, and the gap in between. This gap will be occupied by the pulmonary artery. And here, this is the ascending aorta, and this is the descending aorta, and this is the beginning of the pulmonary artery. And of course, you know that this is the superior vena cava. The superior vena cava is seen here and here and here until you reach the cardiac chambers. Then If you look here and you see this is the superior vena cava, ascending aorta, descending aorta, and this is the site of the pulmonary artery, part of the thymic gland. Then the pulmonary artery looks like an inverted V, and this is the main trunk, and this is the left branch, and this is the right branch. And here you see the ascending aorta and the superior vena cava, and this is the descending aorta. Then once more, this is the pulmonary artery, like the inverted V. This is the main trunk, right, left branch, and right branch. This is the superior vena cava, ascending aorta, and the descending aorta. And each of these structures will enter a specific cardiac chamber. The superior vena cava will enter the right atrium. Then this is the superior vena cava, and this is the start of the right atrium. And this is the superior vena cava, and this is the right atrium. And this is the superior vena cava has entered the right atrium. Then the pulmonary artery will enter the right ventricle. This is the pulmonary artery, and this is the pulmonary artery entering the right ventricle, entered the right ventricle, which is adjacent to the right atrium. The ascending aorta will enter the left ventricle, and this is the ascending aorta, ascending aorta, ascending aorta, and this is the ascending aorta will enter here, and this is the left ventricle adjacent to the right ventricle, adjacent to the right atrium, and this is finally the left atrium, which is a midline cardiac chamber anterior to the spine. And here you can see the four chambers of the heart. This is the left atrium and right atrium. This is the right ventricle and left ventricle. And finally, you have reached the diaphragm and the dome of the liver. Then, few words about the mediastinal lymph nodes. Normal mediastinal lymph nodes are not seen by imaging, and the lymph nodes are only seen whenever they are enlarged. You have 9 anatomic sites for lymph nodes in the mediastinum. The first site is posterior to the sternum, and this is known as the retrosternal or internal mammary group of lymph nodes. The second site is posterior to the superior vena cava, and this is known as the retrocaval lymph nodes. The next site is along the arch of the aorta. These group of lymph nodes are known as the prevascular group of lymph nodes. Then the next group is located between the ascending aorta and the descending aorta above the pulmonary artery. And you see this group of lymph nodes are known as the aortic window group of lymph nodes. The next are located at the division of the trachea into two main bronchi. They are known as the carinal lymph nodes. Those located anterior to the carina are known as the precarinal lymph nodes. Posterior to the carina are known as the retrocarinal lymph nodes. At the bifurcation of the trachea are known as the subcarinal lymph nodes. Then one of the major groups is the hilar or the bronchopulmonary lymph nodes, which are located in the hilum on both sides. And this is the hilar group on the left, and this is the hilar group on the right. The posterior mediastinal group, which are related to the esophagus and the azygos vein, are known as the zygoesophageal group of lymph nodes. And finally, the group around the pericardium, which is known as the circumcardiac lymph nodes, and these group of lymph nodes are intimately related to the diagnosis of non-Hodgkin lymphoma, whether you are dealing with a child or an adult. And frequently, these lymph nodes are associated with pericardial effusion. Then we came to the anatomy of the lung. We want to know where is the upper lobe, where is the lower lobe, where is the middle lobe. Then you know that on the right side we have the upper lobe, the middle lobe, and the lower lobe. On the left side we have the upper lobe, and part of the upper lobe is the lingula, and we have also the lower lobe. Then our anatomic landmark here is the trachea. whenever you see the trachea, you are cutting in the upper lobe. Then you see here the trachea, and this is the left upper lobe, and this is the right upper lobe. Then if you go down, then you will reach the site of the tracheal bifurcation. And the site of the tracheal bifurcation, when the trachea is divided into two main bronchi, the section is also divided into two parts. The anterior part is related to the upper lobe, and the posterior part is related to the lower lobe. Then here, this is the left upper lobe, and this is the left lower lobe, right upper lobe, right lower lobe. Then you should remember, when the trachea is divided, the section is divided. The upper lobe anteriorly and the lower lobe posteriorly. And if you go more down, then you will cut in the lingula and lower lobe on the left side, in the middle lobe and lower lobe on the right side. Then if you draw a line like this, and this is the lingula, and this is the middle lobe, and this is the lower lobe on the left, and this is the lower lobe on the right. Then if you look to the sections like this, and I asked you about what is this part of the lung? Then you look to the tracheal bifurcation. The trachea has divided into two main stem bronchi. Then the section is divided into upper lobe anteriorly and lower lobe posteriorly, and this is the left lung. Then this sign refers to the left lower lobe. And here, of course, the right upper lobe. And if you look here, this is the cardiac shadow. And if you have a section like this is the lingula, and this is the middle lobe. Bilaterally, this is the lower lobe, and this yellow spot is in the right lower lobe. Of course, this is in the lingula, and if you want to locate this mass in the lung, you look to the trachea, then this mass should be in the left upper lobe. Then you remember the mediastinal anatomy, and this is of course the banana or the arch of the aorta, and this is, yes, this is the superior vena cava, and here is the thymic gland. And in this section you are at the level of the heart, then this red spot should be in the left lower lobe, good, and this should be in the middle lobe. You remember there should be a line here. This is the lingula and this is the middle lobe. Then this is the lingula, the blue spot, and if you look here, and this is the site of the trachea, and this is the esophagus, of course, then this is the right upper lobe, and this patient have bronchiectasis in this part of the lung. You are at the level of the cardiac shadow. If you draw a line like this, and this is the lingula, this is the middle lobe, and this should be in the right lower lobe. Then you remember the cardiac chambers. This is the left atrium, which is a midline structure anterior to the spine, and this is the right atrium, and this is the left ventricle, and this is of course the descending thoracic aorta. This patient with pneumonic consolidation, you see the consolidation in the lung with air bronchogram. I will discuss this in details. And this is seen at the level of the tracheal bifurcation. Then you should draw a line like this, and you know that the upper lobe is anterior and the lower lobe is posterior. Then this consolidation is located in the right upper lobe. And this is an hematocele, air containing cavity in the lung. And this is the lingula, this is the middle lobe, and of course this hematocele will be in the left lower lobe. You are right. And this is pneumonic consolidation with air bronchogram at the level of the tracheal bifurcation. When the trachea is divided, then the section will be divided upper lobe anterior, lower lobe posterior, and this is left lung and left upper lobe. Then I have mentioned that you can go by the virtual endoscope, which is a software inside the multi-detector CT, which enables you that you can go inside the trachea or the bronchi or in the colon, in the intestine, in the urethra, in the ureter, any tube in the body, you can do this. In order to do a virtual endoscope for the trachea or what is known as virtual bronchoscopy, you put the patient on the CT machine and you have a regular CT scan of the chest. Then you reconstruct the images in the coronal plane. Then you order the machine to remove all the structures except the trachea and the bronchi. And this is an option which is also provided with the machine, that you can remove any undesired structure from the image. After you got this appearance, which is known as the road map, then you go to a button which is present on the machine, and this button is known as the, I'm sorry for this. Then you push the button which is labeled the virtual camera. Then the virtual camera will open and you start your scanning by putting your pointer here, and you proceed down into the trachea. Then you reach the carina and you also go further down until you reach the third or fourth order bronchi. After finishing the right lung, you go upward into the trachea, and then you select the left main bronchus and go inside the left main bronchus until you finish your scanning. Then this is just an example for the virtual endoscope. Actually, the technique provides you some of the reconstructed images for the trachea and the brainstem bronchi, and these images are valuable for evaluation of tracheal stenosis or strictures post-tracheostomy or any abnormalities in the caliber of the trachea. Also, the virtual endoscope is very good in evaluation of suspected foreign body inhalation in the pediatric age group, while in adults it is mainly directed for evaluation of bronchial invasion by the bronchogenic carcinoma. And you should remember that virtual endoscope cannot diagnose any of the dynamic lesions like tracheobronchomalacia, for example, but these are static images that can help you to look inside the trachea. And the major two advantages in children is to detect an inhaled foreign body which is not detected by the regular endoscope, and in adults to see the invasion of the bronchi by the bronchogenic carcinoma. Then few words about foreign body inhalation. In the you know that the diagnosis is based on the history and the clinical examination. Then many times you have the symptoms like coughing, choking, cyanosis, and sudden wheezes, like for example. Then whenever you are suspecting foreign body inhalation, you may have a chest X-ray, and in a few situations you can detect the radio opaque foreign body, and you know that few percentage of foreign bodies are radio opaque. But these are the X-ray findings in a patient suspected to have foreign body inhalation. In about 30% of the cases, you got normal findings. You cannot see any abnormality in spite of the presence of the foreign body. And the air trapping is one of the common manifestations on chest X-ray, where you see hyperinflation of a lung compared to the opposite lung. And usually, the hyperinflated lung is that on the right side, because you know that the right main bronchus is more on line with the trachea, so the inhaled foreign bodies usually go to the right side. Then the foreign body will allow air to go inside the lung, and during expiration, the wall of the bronchus will collapse on the foreign body, preventing air from coming outside the lung. Then you got air trapping with increased volume of the lung and increase translucency as well. Also, you may get consolidation due to bronchial obstruction by the foreign body, and you may get atelectasis if the foreign body is small and occluded the small side bronchus. And in about 10% of the cases, you can detect the foreign body because the foreign body is radiopaque. And this is the classic appearance of foreign body inhalation on the left side with air trapping. Sometimes we try to have these projections in inspiratory film and expiratory film. You know, this is very difficult with the children, but we try to do this, and if you succeeded, then you can see that the left lung is persistently hyperinflated. It does not collapse during expiration, suspecting the possibility of inhaled foreign body. And then you can also detect the consolidation as you see in this plain X-ray. And you see here an opacity in the base of the right lung. And this is the opacity seen by CT scan. And this is very small arrow points to this hypodense foreign body impacted in the lower lobe bronchus. Sometimes you can see the foreign body, sometimes you cannot see even by CT scan. And this is the case of foreign body inhalation in the left main bronchus with air trapping as seen in the chest X-ray as well as in the CT scan. You see that the lung is hypertranslucent with scanty vascular markings. And if you look carefully here, you can see that this bronchus is patent, containing air, but the bronchus on the left side is occluded by the foreign body, which is detected by the endoscope. Then the complications of foreign bodies will include chronic wheezes, recurrent chest infection, the development of lung abscess, airway obstruction, and maybe may result in death. And virtual endoscope has many limitations. As I have mentioned, the tracheobronchomalacia cannot be diagnosed by virtual endoscope because this is static imaging. In order to diagnose tracheobronchomalacia, you need the true endoscope. The virtual endoscope cannot obtain biopsies or do therapeutic maneuvers. The color presentation of the mucosa is artificial, and that's to say you cannot diagnose by this virtual endoscope any mucosal abnormality like congestion or ulceration. Retained secretions, and this is very important, retained secretions may simulate foreign bodies like mucus plugs, and the secretions will appear as similar as the foreign bodies. And what's very important in the pediatric age group is the radiation exposure, which we should take care about this hazard. Then this is a question for you, and this is a male child, 3 years old, presented by coughing and difficulty in breathing. On examination, there is a stridor and a bronchospastic cough. The chest X-ray is like this. What do you think? Is it a normal, or there is hyperexpansion on the left or on the right? There is right middle lobe infiltrate or right-sided drip fraction. Actually, the true answer is the hyperinflation or the hyperexpansion on the right side compared to the left with some shift of the cardiac shadow to the opposite side. And these findings in a reliable age group of the children is diagnostic of foreign body inhalation. Then the commonest age for foreign body inhalation is in between 1 to 3 years of age, although reported cases are seen in younger children than 1 year in the range of 6 to 8 months. And these are food or toys are the most common aspirated objects. Total airway obstruction may lead to respiratory distress and cardiac arrest. Partial airway obstruction may usually lead to stridor. An obstruction below the vocal cord will produce wheezes. Right foreign bodies are more common, of course, than those on the left side. that the X-ray findings, as I have mentioned before, may be normal, may include hyperexpansion, consolidation, atelectasis, and this is a common finding, which is air trapping. Food matter can lead to inflammation and pneumonitis, and then we do not, or the literature do not recommend the prophylactic antibiotics for those who have inhaled foreign bodies. And whenever it is clinically suspected, then the foreign body should be removed by the rigid bronchoscope. And what do you think about this chest X-ray? This is a female child, 25 months old, presented to the emergency department with an attack of hemoptysis. The child has a 3-week history of coughing and wheezes and was initially treated by antibiotics and showed some improvement. Then you see a radio opaque structure here, and you have to discriminate whether this is a foreign body in the trachea or in the esophagus. As a rule, if you see the foreign body en face, and this should be in the esophagus. If it is seen on its side, like this one in the frontal X-ray, it should be in the trachea. Then if you see in the frontal X-ray the foreign body arm fast, and this is esophageal foreign body, which is confirmed by the lateral view. This is the trachea, and this is the esophagus, which is located, of course, posterior to the trachea. Then what do you think? Is it a tracheal foreign body? No, this is an esophageal foreign body. Then complications of this foreign body include airway compromise, esophageal rupture, erosion of the mediastinal structures, heavy metal poisoning. All these can occur except the last one, which is heavy metal poisoning, because this needs a good time. The foreign body is present at this site to initiate this heavy metal poisoning. Then what do you think about the treatment? Can you follow the passage of the foreign body by serial X-rays, or you do an emergency endoscopy to remove the foreign body, or you give a cough syrup, for example, to allow the patient to cough the foreign body? Actually, the answer is to remove the foreign body by endoscope urgent. And the common sites of foreign body impaction in the children, the foreign bodies in the esophagus, are impacted in these areas except the cricopharyngeal narrowing at the level of C6, the tracheal bifurcation at the level of T6, the ileocecal valve, and the hiatal narrowing of the esophagus. All these are sites of impaction except the ileocecal valve, since most of the foreign bodies reach the ileocecal valve will pass outside. What percentage of foreign bodies pass without intervention? They are in the range of 80% foreign bodies pass in the gastrointestinal tract without intervention. Then if you look carefully here, can you see the foreign body? Yes, the foreign body is a pin, which is located on the right side and is clearly seen in the lateral view. This is a foreign body impaction on the right side. And thank you very much.